Welcome back to The Explainer. We are diving right into part 9 of our breast surgery coding masterclass. Now, in our last session, we wrapped up female breast open excisions, and today, we are pivoting entirely. We're transitioning over to the specific and, honestly, sometimes incredibly tricky nuances of male breast surgical procedures. Listen, coding for male breast surgery isn't just some mirror image of female breast coding. It's got its own completely unique rules, highly specific CPT codes, and some seriously strict medical necessity requirements that we're going to master right now. So here is our roadmap for today's explainer. We'll start with male breast surgery basics, move into true versus pseudo gynecomastia pathophysiology, tackle the CPT hierarchy of 19300 versus 19120, cover modifiers and lipectomy bundling rules, highlight some audit traps and medical necessity, and finally wrap things up with some live cases. Section 1. Male breast surgery basics. If you've been spending all your time coding female breast procedures, it's time to completely recalibrate your mindset. Right off the bat, we have got to clearly distinguish between three very different clinical scenarios. We're talking true glandular hypertrophy, neoplastic conditions, and cosmetic contouring. Really, your job as a coder here is to play detective. You have to look past whatever title the surgeon slapped on the operative report and dig deep into those clinical indications. Ask yourself, are we removing actual functional tissue that's abnormally grown? Are we taking out a suspicious mass? Or, is the patient just looking for a flatter chest contour? Your code selection hinges entirely on nailing these distinctions. Moving to Section 2, True versus Pseudo Gynecomastia Pathophysiology. You simply cannot code male breast surgery accurately without really understanding the underlying tissue anatomy. So here is the fundamental biological difference that absolutely dictates your coding. True gynecomastia is the actual proliferation of glandular breast tissue. We are talking genuine hypertrophy of that subareolar parenchymal tissue, which maps right to ICD-10 and 62. Think of true gynecomastia almost like a dense, heavy knot of fibrous rope. On the flip side, pseudo-gynecomastia is literally just fatty adipose deposition. It's much more like soft packing foam. Now, why does this distinction matter so much? Because removing purely fatty tissue is almost always considered a cosmetic lipectomy by payers, whereas taking out that true glandular tissue, that is a medically necessary mastectomy. And remember, beyond gynecomastia, males develop neoplastic conditions too. We see fibroadenomas, cysts, and yes, male breast cancer. Now, here is a really common trap you need to watch out for. When you are dealing with a malignancy in a male patient, you absolutely cannot just default to the standard breast cancer codes we use for females. No way. You need highly specific ICD-10 C50 series codes that explicitly indicate male breast cancer and specific laterality. Always double-check your tabular list to make sure you've locked in that correct male-specific category. Section 3. The CPT hierarchy, 19300 versus 19220. This is the big one. This is a direct head-to-head battle where the bulk of coding errors actually occur in the real world. Let's break down this hierarchy. Code 19300 is strictly defined as a mastectomy for gynecomastia. That means a diffuse resection of that enlarged glandular tissue we just talked about. Code 19120, however, is very different. It's for the excision of a cyst, fibroadenoma, or other tumor. It's meant for the targeted enucleation of a solitary mass. And it's super important to note that the CPT descriptor explicitly states 19120 can be used for either males or females. So the absolutely crucial takeaway is this. If the surgeon is just pulling out a localized, discrete lesion or a distinct mass from a male patient, you must report 19120. Do not use the gynecomastia code. I routinely see coders mistakenly bill 19300 anytime a male patient has any breast tissue removed, and honestly, that is a massive compliance risk. Remember, 19300 is for diffuse glandular resection. 19120 is for pulling out a specific targeted mass. Let's jump to Section 4, Modifiers and Lipectomy Bundling Rules, because, as we all know, once you finally have the right code, you've got to apply the right rules to actually get the claim paid. Let's think back to our anatomy basics for a second. Breasts are paired structures, right? This means laterality is strictly enforced by payers across the board. If a patient has bilateral gynecomastia resections, you'll typically use modifier 50. Though keep in mind, some payers might require a one-line or two-line reporting format with LT and RT. If it's unilateral, you absolutely must append either LT or RT. Never leave a breast surgery code hanging without its laterality modifier. Okay, let's talk about liposuction. Consider this a bit of an insider tip. You have to be incredibly careful with codes like 15877. A lot of the time, surgeons will use suction-assisted lipectomy as an adjunct to a 19300 mastectomy, just to smooth out the final chest contour. But here's the kicker. Payers frequently view this as an inherent part of the cosmetic result, and they'll just bundle it right into the primary excision. And if it's performed standalone for pseudogynecomastia, remember, that's just fat. It will almost certainly hit cosmetic non-coverage rules and face an instant denial. Section 5. Audit traps and medical necessity. Let's open up the auditor's playbook and flag those high-stakes traps that are basically guaranteed to trigger claim denials. So here is your absolute golden rule for this entire explainer. Your code selection must match the pathology report, period. If you bill 19300 for gynecomastia, but that path report comes back showing only fatty adipose tissue, an auditor is going to instantly strip away your 19300 code and downgrade it to a cosmetic lipectomy. Also, keep in mind that any skin reduction or nipple repositioning performed just to make the chest look natural after the gland is removed, that's typically bundled into the primary code. Don't even try to unbundle these unless distinct, separate reconstructive criteria have been formally documented and met. Finally, Section 6, Live Cases and Episode Wrap-Up. Let's transition from passive learning to active problem solving. It's time to put our decision tree to the real test. Okay, case number 1. We've got an operative snippet from a 24-year-old male who was completely unresponsive to medical management. The operative report specifically calls out excising dense glandular breast tissue on both the right and the left sides. Notice those weights, 120 grams and 110 grams. Those are significant. But most importantly, the actual tissue type is explicitly defined by the surgeon. So how do we process this one? Well, following our logic tree, the confirmed dense glandular tissue points us squarely to true gynecomastia. It completely rules out a simple mass or just fatty tissue. The extensive nature of the removal definitely justifies the mastectomy code. And because it was performed on both breasts, the bilateral nature lands us perfectly on 19300 with a modifier 50. Now let's contrast that with case 2. Here we have a 56-year-old male presenting with a solitary, palpable 2-centimeter retroareolar mass in the right breast. The surgeon goes in, removes just that specific mass, and the path report comes back confirming a solitary fibroadenoma. All the normal surrounding tissue is left completely intact. Because this is a highly targeted enucleation of a discrete mass, rather than some diffuse glandular excision, our decision tree strictly mandates code 19120. We are not treating gynecomastia here, guys. We're just removing a benign tumor. And since it was only on the right side, we simply append modifier RT. Final code 19120-RT. This is literally the perfect example of why you can't just blindly slap 19300 on every male breast procedure that crosses your desk. So, to summarize today's explainer, here is your quick must-do checklist. Always differentiate between true glandular gynecomastia and simple fatty tissue. Reserve 19300 for extensive glandular mastectomies and use 19120 for targeted mass excisions. Make it a habit to verify your pathology reports before dropping that final bill and constantly be on the lookout for those tricky liposuction bundling pitfalls. Next time, we are moving into the highly complex world of breast-conserving surgery and partial mastectomies. We'll be breaking down CPT 19301, lumpectomies, and exactly how to handle margin re-excisions. But before we go, I want you to think about something. If a surgeon goes back in during the exact same operative session just to take wider margins, do you know if you can actually code for it twice? Think about it. Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in part 10.